Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by educational grants from Amgen, AstraZeneca, Daiichi Sankyo, and Novocure. Hello, I'm Dr. Stephen Liu, Associate Professor of Medicine, Director of Thoracic Oncology at Georgetown Lombardi Comprehensive Cancer Center in Washington, D.C. Welcome to this program entitled Expert Insights on the Management of Lung Cancer, a podcast series. I am privileged to be joined today by Dr. Dagogo-Jack, Assistant Professor of Medicine at Harvard Medical School, thoracic oncologist at Massachusetts General Hospital in Boston, Massachusetts. The topic of today's podcast is advances in the management of malignant pleural mesothelioma. Are you up to date? Malignant pleural mesothelioma is one of the more challenging thoracic cancers to treat. Arising from the pleural surface, patients are often quite symptomatic, and there's often a delay in establishing the right diagnosis. The most important risk factor, as we know, is asbestos exposure, and due in part to public policy changes, we've seen the incidence of mesothelioma decrease in the U.S. over the past decade, but we still expect over 3,000 cases a year in the U.S., and in other parts of the world, the incidence continues to rise. The role of surgery in resectable mesothelioma continues to evolve, but there's almost always a role for systemic therapy. Now, medical therapy for meso has largely been chemotherapy with cisplatin and pemetrexed. That was established by a phase 3 study led by Dr. Nick Vogelsang, published back in 2003. Adding pemetrexed to chemotherapy improved outcomes and became our standard of care. But even with that, the outcomes were quite poor, with the median survival in that study limited to about a year. While the addition of bevacizumab to that cisplatin pemetrexed backbone did improve outcomes, that is not an approved agent in the U.S. for mesothelioma. And we've had no approved change to our first-line standard of care for almost 2 decades until the recent approvals of immunotherapy. But before we talk about that modality, one of the big challenges for mesothelioma is drug delivery to the pleural space. And I know that there's a novel approach to therapy that's not exactly a medical therapy, maybe more of a device. Can you tell us a little about TTF, or tumor treating fields?
Stephen, happy to. So as you mentioned, for a while, basically since 2003, all we really had was chemotherapy. And that in some parts is due to having a rare disease, which kind of complicates conducting very large-scale studies. And so this study that we're talking about is actually a phase 2 study looking at a device called tumor treating fields. And it's based on somewhat complex principles, but kind of suffice it to say, it basically is regional delivery of alternating electrical fields with the idea that you can impact the mitotic spindle assembly and prevent the cells from making copies of themselves in essence. And so TTF was first approved for glioblastoma, and it's been explored in mesothelioma. And what this study explored was the combination of this vest encompassing the tumor treating fields in combination with platinum pemetrexed chemotherapy for reasons you've described. And really the point of this study was to kind of establish the overall survival with this approach. And what they showed in this study was a median overall survival of 18 months, which was higher than what we've historically seen with chemo by itself, which is about a year. And so this was approved, this particular device was approved in 2017 under a unique pathway, which is the humanitarian device exemption, which is really implemented to encourage companies to innovate for rare diseases. And so it is an approved option, but it does take a bit of expertise to get it up and going in an institution, but it is available for our patients. And it's important for it to have effect for patients to wear it for 18 hours out of the 24-hour day. So there is a commitment.
Yeah, I've seen these for GBM and for mesothelioma, and they're not as heavy as I thought they'd be. I had a chance to try them on. They're not as heavy. So I think that sort of novel approaches to really attack this cancer are what's needed, because it's such a challenge to deliver effective treatment into that space. One of the main advances we've seen really over the past few years has been the integration of immunotherapy, which really does solve that sort of drug delivery problem. it's certainly a welcome addition to our treatment options. Maybe immunotherapy has changed the treatment paradigm for so many of the cancers we treat. Can you tell us a little about immunotherapy and mesothelioma?
Yeah, so much like our other diseases, immunotherapy started in the relapse setting, right? People tried single agent PD-1 and PD-L1 inhibitors, and then, as we'll talk about a little bit later, moved it to the frontline setting. And so the first study was unfortunately not, one of the first studies unfortunately was not a success. This was looking at tremelimumab. In the determined study, randomized patients to receive placebo versus this, and tremi wasn't any better than placebo. And so fortunately, we did not stop there. So there were other studies, including KEYNOTE-28, which basically started patients who had PD-L1 positive tumors to receive PD-1 inhibition and showed that there was some promising activity there. That was a selected population. I emphasize that study because the subsequent studies, all again single-arm phase 2 studies that explored Nivo, Pembro, as well as avelumab, showed comparable activity in unselected patient populations. And the activity is to the tune of maybe objective response rates 20 to 30%, sometimes as low as 10% in some studies, and a median progression-free survival of around 3 to 6 months. There was an intriguing signal from a MAPS-2 study, which basically was a non-comparative phase 2 study that assigned some patients to receive Nivo by itself and others to receive Nivo plus IPI. I say it was an intriguing signal because we saw a bump up or kind of an increase in the efficacy, the objective response rate, a near doubling when you added IPI, and also an improvement in overall survival. But again, this was not meant to compare the two treatment arms, but it was food for thought that perhaps a doublet combination might be the way to go. I do think it's important to note that in non-small cell lung cancer, we know that PD-L1 is predictive of responsiveness to this therapeutic approach. In mesothelioma, that hasn't been exactly clear in that there's inconsistency across studies about that biomarker. So we're still seeking out biomarkers. I think it's important. I talked about a bunch of phase 2 single-arm studies. We have had a couple of randomized studies of single-agent immunotherapy. The first was the PROMISE study that compared pembrolizumab to standard of care. And so this was in the second-line setting, we often use gemcitabine or navolbine. And this study, unfortunately, was a negative study. Pembro was not superior to either of these approaches. More recently, we've seen the CONFIRM study, which compared again in that second line after patients had received the standard of care chemo to either receive nivolumab or best supportive care. And here we did see a benefit both in overall survival and PFS, suggesting that this is better than doing nothing. And we're still kind of figuring out the positioning, whether it's second or third line.
So to recap here, we're seeing some activity in patients with previously treated mesothelioma. And when we look here, PD-L1 not really a strong predictive marker in that setting. The potential for durable responses, which we've seen, I think both of us have seen those in our clinic. But as we know from all of our other cancers that we're treating with immunotherapy, the potential for impact really is much greater in that first line setting. Right now, we do have first line data in mesothelioma as well. Can you bring us up to speed there?
Yeah, so these data are very exciting, I would say. And it really was the biggest advance that we had since the incorporation of doublet chemotherapy. So this is based on the CheckMate 743 study, which randomized patients to receive IPI-Nivo, again, based on promising signal of the combination in phase 2 studies compared to chemotherapy. And this study with the primary endpoint of overall survival demonstrated an improvement in overall survival with the immunotherapy doublet. In all comers, the improvement was in the order of 4 months, so 14 versus 18 months. But when you really drill down and look at the data, we know that there's different phenotypes of mesotheliomas based on histologic subtype. So there's an epithelioid subtype that we tend to think of as more chemoresponsive and better behaving than the non-epithelioid subset. And when you really look at that data, there seemed to be a significant magnitude of benefit for the non-epithelioid subset on the order of 8 months with chemotherapy for median overall survival compared to 18 months. When you look at epithelioid, there was still a benefit, but it was a little bit less of a dramatic effect, 16 versus 18 months. And so when I look at those data, I tend to think that this is definitely, my treatment of choice for patients with non-epithelioid tumors. And I think that it's a reasonable option compared to chemotherapy in patients who have epithelioid mesothelioma.
I was really struck by the two curves that are side by side. And so in the non-epithelioid type, this is a huge benefit. And that's a big deal, ABI, because our standard treatments don't really work that well in that subset, right?
Yeah, they're pretty poor, I would say. And I think our standard treatments, and I know that we'll talk a little bit later about surgery as well, even surgery aside, chemotherapy, what we have for this subset is not very efficacious. And based on my clinical experience, we can have some pretty rapid symptomatic and rapid progression of disease in this subset of patients. So it really is an area of unmet need. And so it's rewarding and kind of refreshing to see a signal of activity in that subgroup of patients.
So I think there's universal agreement here for a non-epithelioid malignant pleural mesothelioma. Our frontline standard of care really should be the combination of nivolumab, ipilimumab as of now. Let me put you on the spot, though. Unresectable, advanced mesothelioma for epithelioid type, what is your go-to today off trial?
I think it depends on the patient and the conversation. I think that there are three potential options that I think about. One is chemo, one is ipi-nivo based on that study, and the third is a clinical trial. And I bring up a clinical trial because I think one kind of approach that is worth considering that has been widely adopted in non-small cell lung cancer is the chemo plus immune combination. And we've seen two phase 2 studies now, the Australian DREAM study, as well as PRECOG 0505, that have demonstrated very promising activity of the combination of chemo plus durva in largely epithelioid population. And so we do have that study ongoing in the phase 3 setting. And so I do think about that for patients. And for other patients, I really look at their functional status, their comorbidities, autoimmune disease profile, et cetera, to inform whether or not I reach for chemo versus ipi-nivo.
Yeah, I think that's pretty reasonable. I think that for someone that's not too symptomatic, I really do reach for nivo-ipi frontline. I think the potential for something durable is really appealing. The benefit was a little less impressive, but there was still benefit noted. So I agree that I think it's a good option for someone who's symptomatic. You have to wonder if you're going to get a second shot at treatment, and if you're not going to be in that responder, since you don't have great predictive markers, we worry a little bit about attrition, and chemotherapy is maybe a little more reliable in some aspects. At least there's the preconception that it is. So I think the combination of chemo IO does make a lot of sense, and hopefully we'll see these studies read out. Are we expecting results sometime soon?
I wish, but I think they've just started enrolling, and there are larger studies in a rare disease subset, but I think the investigators have wisely opened across the world. And so it's an international study, and hopefully we'll get some data soon. They're aiming to enroll hundreds of patients.
Yeah, I think that's going to be a very important study. And so as we're seeing our patients in our clinic with advanced mesothelioma, we have the option of immunotherapy, very important one, the option of tumor treating fields. When I look at our management of non-small cell lung cancer, we often rely on sequencing, on NGS, molecular testing to help guide therapy. Is there any role for that in mesothelioma?
I think that as we've recognized over the years in mesothelioma, we need more therapies. And so clinical trials have a very prominent role for this disease. We're entering an era where there are several studies exploring targeted approaches for mesothelioma. So I do not think at this moment that NGS will inform first-line treatment, but I think it is of increasing value now for second-line and beyond therapies. For example, there are emerging therapies that are targeting the Hippo pathway, which is dysregulated in about 60 to 70% of mesotheliomas, and in particular NF2 inactivation, where we see it in about 30+% of mesotheliomas. These are oral therapies. And then there's also a push to target MTAP deficient tumors with PRMT5 inhibitors. MTAP deficiency is something we see in about 25 to 30% of mesotheliomas. And importantly, it's enriched in the non-epithelioid subset. And so in my clinical practice, I am looking towards genotyping in patients who are interested in clinical trials, and in particular in the second line setting and beyond.
Now, the genetic change I usually associated with mesothelioma in my head, a lot of work done at the NCI, is BAP1. Can you tell me where we stand with that for mesothelioma?
Exactly. So BAP1 it's an interesting one in that somatic BAP1 mutations, that is non-inherited BAP1 mutations, are seen in about 50 to 60% of mesotheliomas across studies. No particular predisposition in epithelioid versus non-epithelioid. So it's a uniform alteration that we see. There are germline conditions that can actually, or predisposition syndromes that can lead patients to be at increased risk of developing mesothelioma as well as melanoma and other cancers that kind of cluster around BAP1 alterations. To date, we haven't found any therapies that are selectively beneficial for BAP1 altered mesothelioma, but there's been a lot of elegant work being led by the group in the UK and also at the NCI looking at leveraging kind of the mechanism of action of BAP1 alterations to look at PARP inhibitors and other therapies in this setting.
Yeah, we've seen a lot of interesting data over the past year, some promise with immunotherapy, some negative studies as well. Let me ask you maybe a little bit of a controversial question. Today, 2021, 2022, is there any role for surgery in mesothelioma?
I think it depends on who you ask. So internally at my institution, we are still doing surgery. I think for surgery, it's very important, right? We've seen across studies, we don't have the best studies, I'll admit, to tell a best kind of randomized, strong data demonstrating that surgery definitively improves outcomes. But when you look kind of retrospectively at large data sets and at the few studies that have attempted to explore this, we do see that there are select subsets of patients who live longer when they can get multimodality therapy. I think that you have to be with a surgeon who has expertise in treating mesothelioma because the surgery matters. And I think we have to remind ourselves that unlike other diseases where it's more common to render someone R0, to remove all evidence of disease, for most people with mesothelioma who undergo surgery, they are going to have some disease left behind. And so the intent is to kind of elongate or prolong the relapse-free interval. And so these surgeries can be quite a lot on the body. There was kind of a push towards pleurectomy decortication and leaving the lung intact, so away from the historical standard of extrapleural pneumonectomy. But even then, we have to carefully select our patients, do upfront studies to ensure that we're not picking people with more advanced disease who may not benefit from this approach.
Yeah, well put. I think that we need to steer away from dogma here, and I don't think it's right for everyone. But I agree that, with patient selection and experienced academic center, I do think that there can be a role for the right patient. Now, I just think overall, it's refreshing to finally see positive change in the treatment of mesothelioma. Immunotherapy, powerful tool, the potential for durable, meaningful immune-mediated responses. That's something that we're all embracing. And, unfortunately, it won't work for everyone. And for those patients, novel approaches like the TTF, Tumor Treating Fields, give us something that we haven't had for a long time, and that's options. And over the next few years, I'm sure that we are going to continue to refine how we deliver immunotherapy. I am a believer that chemo-IO, I think, will be the answer in the future. We have to show that. I think there will be other treatments that help maximize the benefit. We're waiting for the results of these trials, novel biomarkers to really guide the use of these treatments. So to everyone out there, stay tuned for what promises to be, I think, an eventful few years for the treatment of mesothelioma. So with that, and looking at the clock here, Ibi, thank you for your time, all your expertise, and really a great discussion.
Stephen, thanks for having me, and thank you for kind of steering the direction of this conversation and also chiming in very useful points. And I hope that we are all becoming increasingly excited about mesothelioma because we're really making progress, hopefully, for treatment of this disease.
Yeah, no room for nihilism here. We've got a lot of great options. And to the listeners, thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.